Good afternoon. This is Dr. Lou Foley, one of the Exam Pro faculty, and we are going to be starting our webinar here. This is a makeup webinar for a session that was missed last week. Give me 1 second. I'm going to set up one thing from a technology standpoint. So you're going to see the screen go blank here for just a second. And bear with me, we will begin momentarily. All right, we are good to go. My apologies for the brief delay there as I got the technology set. So I again am Dr. Foley. This is the Exam Pro structured case, case list defense webinar makeup session being conducted today, Sunday, September 25th. And I'm going to go ahead and get started here just to make sure everybody is on the same page with the technology. There is a control panel that looks similar to this, although not identical, that you will use during the GoToWebinar session. The little orange box with a white arrow allows you to expand or collapse the control panel so you can get it out of your view during the webinar. The upper portion of the control panel is the most important thing that I'm going to tell you, which is that you do have a choice whether you participate with the microphone and speakers from your computer or whether you participate by using a telephone. Telephone can be advantageous if you have an environment with a lot of background noise. The audio setup, you click on that, you go to use telephone, and if you choose to do this, you'll be given a number to dial in, an access code, and an audio PIN number. The most important point that I'm just trying to make is that if you do use a telephone, you must make sure you do that audio PIN step, because if you don't do that, I cannot unmute you to participate in the webinar. We don't use the typing in of questions feature, so please don't do this because I will not know that you have done that. We do take volunteers for the webinar by using the raise a hand feature. So if you are interested in being in the hot seat, then I will have you click the raise a hand feature, and that way I will know that you are volunteering. We do record all of our webinar sessions. If you need access to a recorded session, contact the Exam Pro staff for information about that. And with all of those obligatory disclosures done, we're going to get right into it. And so what I'm going to do first is I'm going to get the case lists so that we can do case list defense. Give me 1 second as I bring up the case lists. And what is going on here? Hold on, there we go. Okay, case lists. So at this point, now is when I am looking for volunteers. If you are interested, if you will click the raise a hand feature, then I will start bringing people into the hot seat. Dr. Wilson, if you are there, I'm going to go to you first.
Hi, I'm here.
Okay, let me get your case list. Now, let me just see if it's in a different. Okay, let me go back. It's not there. Hold on. Okay, so I'm going to ask, did you submit a case list to ExamPro, Dr. Wilson?
I did. I submitted, I think it was at the end of August.
Okay, and have you seen it at a webinar? Have you been on the webinars before and had it be pulled up?
I have been on the webinars, but I have not had it pulled up. I didn't realize that for many of these, my hand
Here it is.
down.
So
Okay.
the reason I was asking this question is the database, it's a remote database that I'm going into here to get your case list, and it's a little finicky. So sometimes I have to manipulate it to get it to show all of the lists, but yours came back up. So we are good. Which section of your list would you like me to work from? OB, office, or GYN?
Could we do OB, please?
Sounds good. Give me just 1 second to look at the list. I'll tell you what, let's talk about case number 26.
Okay.
So my first question, I see here LGA suspected macrosomia listed as a delivery or postpartum complication. What's the difference between LGA and macrosomia?
Macrosomia is a weight-specific cutoff that is used to define a fetal concern for being large. So, for example, cutoffs can be sometimes 4,000 grams, 4,500 grams, or 5,000 grams.
Okay, so you use different cutoffs in different situations, or do you have a cutoff that you use in your practice?
The one I use in my practice is for 4,000 grams.
And LGA is defined as what?
It is the 90th percentile of estimated fetal weight, or an abdominal circumference greater than the 90th percentile.
Okay, now you mentioned it here as a complication. How did it impact your management?
It did not, in the fact that it was something that I discussed with the patient, that the baby appeared to be macrosomic with an estimated fetal weight of over 4,000 grams, but that I discussed that was not an indication for an induction, but rather it was the oligohydramnios that was noted. That was the reason for the induction before 39 weeks.
What was the reason for doing an ultrasound that led to the diagnosis of oligohydramnios?
That would have been for AMA. I think I typically will always get growth ultrasounds, generally at around 36 to 37 weeks.
Okay,
Those
and
routine growth.
in diagnosing oligohydramnios, what criteria do you use?
A maximum vertical pocket of less than 2 centimeters.
Okay, and then you went ahead and did an induction of labor.
Yes.
How did you do the induction?
I started with cervical ripening using misoprostol, and then as well during that process of cervical ripening, that was when I think that it states here in her case that there was concern for a category 2 prolonged fetal bradycardia.
Okay, what is a fetal bradycardia? How would you define that?
That would be defined as a fetal heart rate of less than 110 beats per minute.
What's the difference between a deceleration and a bradycardia?
Deceleration would be a decrease in the fetal heart rate that is, it can coincide either with contractions or outside of specifically with a contraction where you would have either head compression or a late deceleration, but generally it is resolved within a minute or two. If it goes beyond 2 minutes, then it's considered a prolonged deceleration, and if it's beyond 10 minutes, then it would be considered either a change of baseline, or if it's under 110, then it would be considered bradycardia, prolonged bradycardia. So I guess to answer the question, a deceleration would mean that there was a return back up to baseline.
Okay, so in this particular case, you had the bradycardia, and that led you to do a cesarean delivery.
Yes. After attempting intrauterine resuscitative measures with lateral position changes and maternal oxygenation, and due to concern for prolonged bradycardia with non-responsive intrauterine resuscitation, that was when the decision was made to proceed with a primary cesarean delivery.
Okay, so let me ask you this. What did you do for intrauterine resuscitation?
This was maternal oxygen, as well as lateral position changes. Discontinued, well, I'm sorry, no, she had misoprostol, so the cervical ripening agent cannot be removed at that time. And that was all at that time.
Okay, I'm going to stop here. I'm going to give you some feedback. So,
Okay.
I think, first of all, discussion of large for gestational age macrosomia, I'm completely comfortable with that.
Okay.
The way you described it, and you happen to use a threshold for macrosomia of 4,000 grams, that's fine. It's not an indication for induction of labor, which is really a key point. If you get into this discussion in the exam, that's you made it clear. There was another good indication here with oligohydramnios. The criteria that you used are appropriate for using the maximum vertical pocket less than 2 centimeters. You could also use an AFI less than 5, although the maximum vertical pocket is the preferred approach. So I was happy to hear you say that. Moving towards induction with cervical ripening, again, being able to talk about the agents that you use and how you manage them if the patient is or is not responding is an important point. And you pretty much jumped right into the fact that you didn't get very far because of the fetal heart rate changes. In talking about the fetal heart rate changes, one of the things that caught my eye here is the category 2 prolonged fetal bradycardia, because a category 3 tracing could also include a bradycardia. So I think about the definition between category 2 and category 3 and the definition between a deceleration and a bradycardia as being important, and really revolving around the presence or absence of variability in the tracing, and also the length of time for which the deceleration persists. So I think you were talking about that length of time as part of your definition. So that I think is very important to be very specific about those definitions if you're asked about this in the exam. I did not ask you about the uterine tachysystole, but that's another definition I think you have to be very specific and clear on if they ask. And then for the failed intrauterine resuscitation, this is fairly straightforward, just kind of background information. What are the things that you do in this situation? Position changes, stopping the induction agent if you can, and then some period of observation during which time you'll prepare for a C-section if needed. I think that pretty much covers it. I know I'm moving kind of fast. I don't mean to. We talked about a lot of different issues in that one case. Any questions for me before I let you out of the hot seat?
No, I guess, would they potentially mention the APGARs in this case, or would that be?
I did look at the APGARs. Let me ask you this. What is the significance of a 1-minute APGAR?
That is generally can be utilized to look at whether the fetus was considered to be in distress at that time of birth. And then at your 5-minute APGAR, that's generally a sign of the resuscitation that's been done to the fetus.
Okay, so I would argue that the 1-minute APGAR is not very predictive of how the fetus is going to do. It really doesn't have any long-term significance. Would you agree with that?
Yes. Yeah.
So when you have a lower 1-minute APGAR, I don't think it gets as much attention. As long as the 5-minute APGAR is 7 or greater, I would be surprised if they ask about the APGAR. When you have a lower 5-minute APGAR, then you usually should have an additional score assigned at 10 minutes and potentially additional scores beyond that if the APGAR doesn't improve. And those are the cases where I would be more inclined to think they'll ask about how do you assign an APGAR score, what are the different components of APGAR scoring, and what would be the significance. And so I'm not anticipating with this case where your 5-minute was 7 that it's going to get much attention.
Okay.
Okay. All right, good.
Okay, thank you.
You're welcome. I am going to keep moving and bring our next person into the hot seat here. Dr. Oh my, hold on one second. My list of people suddenly shifted as I went to click on the next person. Dr. Carballo, are you there?
Yes.
Okay, if I come to you next?
Yeah.
Which list would you like me to pull up?
Perhaps office practice.
All right. Give me 1 second to look at the list. Let's talk about case number 9.
Okay.
So what did you tell the patient about the HPV vaccine?
So the HPV vaccine provides immunity against 9 common problematic strains of HPV, and the FDA and the recommendations have expanded, allowing it up to age 45. The HPV vaccine will not protect you against, or will not treat already exposed and obtained viruses that somebody may have, but they would have the option to receive that vaccine to improve their, or to provide protection against these other strains that they may or may not have been exposed to yet. It is most effective when given in adolescence, and those only need 2 shots at that time. At her age, she would need a 3 injection series, and it could provide some benefit. So it would not treat her prior history, it would not treat the history of HPV that she previously had, but could prevent additional strains.
What strains of HPV are in the vaccine?
6, 11, 16, 18, and then some additional high-risk strains where I would need to double check the numbers, but I think 31, 33, I'd have to look, but there's 9 total, and they're still high-risk strains, but they're not the main culprit, 16, 18, of causing cancer.
Now, I don't think of 6 and 11 as being particularly high risk. Why are they in the vaccine?
They are the most common cause of genital warts.
So in a young patient who gets the vaccine at the ideal time frame, what is the relative risk reduction for genital warts or for cervical cancer with the 9-valent gardasil?
The exact number is something I would need to look up, but it does provide significant risk reduction, which is why we're seeing an overall decline in incidence of cervical cancer and probably genital warts as well. I would ballpark maybe 90% risk reduction. I'm not sure.
Okay. We've talked about cervical cancer and genital warts. Any other benefits of the HPV vaccine?
Those are the ones we think about most from a gynecology standpoint, but any HPV related cancer, so that could include head and neck cancer, anal cancers. It prevents transmission to other partners who could be at risk for those other squamous cell cancers. So yes, those are additional benefits.
If a patient has had the full HPV vaccination schedule, does this change the recommendation for cervical cancer screening for that patient?
No, it does not. They still should complete the routine cervical cancer screening per the ASCCP guidelines.
If a patient received the HPV vaccine in your office and called you a week later reporting a home positive pregnancy test, what would you tell her?
That is fine. She does not need to do anything different or be concerned for the well-being of her fetus.
Okay, so she should return as scheduled for her next dose?
I would, it's okay, like it is not a live vaccine, so it is okay to receive, but I tend to not give extra vaccines in pregnancy besides the ones indicated.
Okay, so did I hear you correctly that HPV is something that is considered acceptable to give in pregnancy?
It is acceptable.
Okay. Okay, I think I'm going to stop there. I was just making sure I'd covered everything. Let me give you some feedback and then we'll go from there, okay? So the first thing, I was going to ask you why the patient declined the vaccine. Do you know?
I think she just felt like, also, I guess we talked about number of partners as well. She was like, I'm in a monogamous relationship and I don't think that she felt like she wasn't going to get as much benefit from it at her
Okay.
age.
Completely understood. And I think that this is one thing that we do have to keep in mind. Although we recommend it to all the patients up to age 45, the benefit, as you stated during your answering of the questions, is greatest in younger patients before sexual activity actually would be the ideal time to get it, which is why it starts at age 9 and the target age is age 11 to 12 for routine vaccination. A couple of things. You gave me a lot of really good information. I love the fact that when you talked about the vaccine and how you counseled her, that you mentioned it was not treatment, given that she had a history of HPV, that it wasn't treatment for any past exposures. There are 9 strains, 6, 11, 16, 18, and 5 other oncogenic strains, like you said. I don't even worry about memorizing the other 5. I think it's probably more problematic that you'll say one that's not right.
Okay.
I think if it's something you can always look up, even though they're not gonna. They may like say, really, you can't remember the other 5. Don't let that phase you. Don't stress about that. 6 and 11 are there for prevention of genital warts, and they do reduce the risk for genital warts by approximately 90%. 16 and 18 are responsible for the bulk of cervical cancers, approximately 70%. When you add in the other 5 types, then the cervical cancer risk reduction approaches 90% as well. Okay, so I think 90% is a good number.
Lucky.
Yeah, well, he was probably an educated guess. You probably had heard something like this and your brain knew it. So I thought that was good. We do have to think about the fact that cervical cancer and genital warts are not the only benefits, which especially weighs in heavily why males are recommended for the vaccine, because of the prevention of ENT, head and neck cancers, anal cancer, penile cancer. All of these are reduced with vaccination. Let's see, cervical cancer screening does not change regardless of having been vaccinated, which you were correct about. HPV vaccine plus a positive pregnancy test following vaccination. I do agree that I would not be concerned. There is no evidence of teratogenic effect, but my understanding is that the package insert, I think, still says don't give during pregnancy. I think the reason is because of a lack of safety data. So there's no, it's still, I think there's a registry for this. And I have to be honest with you, I haven't looked at it in the last couple of months. So if there's been a change, then I apologize, but I think it's still not recommended.
That's probably right. Once people are pregnant, they stop seeing me. So
Got it.
I just knew it wasn't live attenuated.
Yes.
Typically wait till after pregnancy to give it if somebody's due, but I guess I just didn't know why.
Yeah. So I would advocate that the right answer is I would not give any further doses during pregnancy, and I would resume vaccination during the postpartum period.
Okay.
There is no contraindication to giving it during breastfeeding, so you can resume during the postpartum period. Okay, I'm going to stop there. Any questions for me before I let you out of the hot seat?
No, thank you.
Yeah, thank you. Just give me 1 second. I'll move you back over. And then let me get the next person in the hot seat here. Dr. Akonwande, and I apologize because I'm sure I'm not saying your last name correctly. Are you there? Ruby Akonwande? Going to come to you next if you are interested. I saw the raise a hand, so I think you are. I think you are self-muted, so I can't hear you. If you can click the unmute, then I should be able to hear you. I'm going to try muting and unmuting you again. Dr. Equinande, if you can hit the unmute button, the system is telling me you are self-muted. All right, I'm not able to hear you. I'm not sure because I can't tell if you actually know that. I think you probably can hear me talking, but the bottom line, oh, wait, did you figure it out? No, okay. So bottom line, if you are on a telephone, you may have the issue of the PIN number, but I am going to try one more time. Again, trying to unmute you here, Dr. Equinande. Okay, I'm going to move on because I'm not able to unmute you. I may come back and try to see if the problem is fixed after my next one. So just give me a second here. Dr. Fish, can I go to you next?
Yes.
Okay, I can hear you just fine, so that's reassuring. Just one second, I will get your case list. Okay, which list would you like me to look at?
I would like to go to gynecology, and I actually have a case that, I feel like they're going to ask me some questions about.
Okay, which
And
case?
Case number 4.
Let me take a look at it.
I think if you guys have the same list that I have. No, I think this is like an old list or something because that's not the case that I was going to look at. It was under operative hysteroscopy. Do you have that one?
This is operative hysteroscopy. What is the age of the patient?
She is 27.
Okay, so I don't see that on this list.
Huh.
Did you move her around, or was she maybe added at the end?
Yeah, I mean, it may have been just an incomplete list.
So what I would say, you can definitely submit an updated list. Let me go back and see if there are any. Let me see if there's any others. Hold on one second, because I'm gonna see if you have a list in the August. Just one second. Let me just look here. And sometimes they stick in different places. I don't see it there.
I think I had submitted it for review, so I don't know what list you guys have because that was pretty complete at that time.
So let me go back to the list that this is, again, a centralized database with exam pro. I'm just going to go back to the list that we have, and then we're going to look at it one more time, make sure that it is not correct, and then I'm going to just send them a message at the conclusion of this webinar. And I would recommend for you, I'll send them a message telling them you're going to send in your updated list, and could they swap it out. Let me just go one more time just to make sure. Sometimes.
Do you want me? Yeah, I might be able.
Tell me about it.
I might. Okay, that sounds good.
Because I don't have the capability right now to email and get it because I'm logged into their database, so I can't do that in real time.
So let me just.
Yeah, what were you gonna say?
You want me to just tell you about the patient?
Yeah.
Okay, so this is a 27-year-old G4 P4, and she was pregnant, and my partner put in IUD while she was pregnant. Her urine pregnancy test was negative in the office, and then we're pretty sure she was like already pregnant at the time the IUD was placed. And she switched to me. I ended up doing her repeat C-section. I couldn't find the IUD at the time of C-section. I searched and I didn't find in the placenta, didn't find it anywhere. And so then postpartum, this is the part that's not good. I ended up getting an x-ray because I thought, I couldn't find it at the time of C-section. So I thought for sure it was in her abdomen. And so then I brought her back for a diagnostic laparoscopy. I couldn't find it in her belly. And then I ended up doing a hysteroscopy, and then it was in the lower uterine segment, and I was able to pull it out. But I'm just like wondering if they're gonna, get on me about like not repeating an ultrasound to make sure the IUD wasn't like in the uterus. after
Yes.
her
So wait, I want to ask you, I have a couple of questions here. Let me ask you and then see where this goes. First, I want to go back to the beginning of the presentation. She had an IUD placed, during which time she had a negative pregnancy test, and she was then diagnosed as being pregnant a short time later.
Yes.
How far after the placement of the IUD?
I think like 2 weeks later, for some reason, she took a home pregnancy test and it was positive, and then she came back to the office.
Okay, and then was an attempt made to remove the IUD at that point, and if so, why not?
Yes, it was. My partner put a speculum in. Actually, I think I might have put a speculum in very early on, and I couldn't see the strings anywhere. And we were not able to see the strings on speculum exam.
Where was the IUD in relationship to the pregnancy on ultrasound?
Yeah, she had an ultrasound with, I think we sent her to MFM for an ultrasound, and I don't think they were able to find the IUD at the time of her pregnancy ultrasound, I want to say. I don't think I could see the IUD on ultrasound either.
Okay. So let me fast forward. I'll come back to that in a second.
Okay.
Let me fast forward. You knew going into this, well, this is probably a critical question. Going into the C-section, you expected to find an IUD even though it was not visible on ultrasound during the pregnancy?
Yes, I did. We did.
Okay, so given that you were expecting to remove the IUD, but you hadn't seen it on ultrasound, did you contemplate prior to the cesarean delivery that you might need to do some type of imaging in the operating room?
Yes, I thought about that after the fact, but she came in labor at like 38 weeks, and she had 3 prior C-sections, and it was at night, and I was the only doctor on call. And so I ended up just taking her back for a repeat C-section, and I was kind of worried about, just closing the uterus up and, finishing the C-section. I was like, I swept the uterus twice, like we always do on all the C-sections, and I look at the placenta. And I mean, it wasn't like I wasn't trying to look for the IUD, but I didn't order like I didn't order like an X-ray or, anything like that at the time of C-section, just because of the timing of the delivery. It wasn't at an ideal time. It was like in the middle of the night.
What type of IUD was it?
It was a Mirena.
What are the dimensions of a Mirena?
It's probably about, I'm not sure, but I would say it's about maybe 2 centimeters in length and maybe 2 centimeters wide.
Okay, so I'm gonna back up. I have a couple of comments about this. I do think this is an interesting case, and I would like to see it on paper. So I'll look for, if you submit your list, I'll make sure to take a look at that. In listening to what you presented to me, I will tell you what I'm thinking. One of my concerns is that initially, if you couldn't see the IUD on the early ultrasound, I'd be worried that I would have suspected the IUD was not in the uterus, and that's why she got pregnant.
Okay.
I know that the time frame may suggest that that wasn't even plausible. The bottom line is, I would expect to see the IUD on ultrasound with the early pregnancy. So that's one question. The next thing is, at the time of cesarean delivery, I would definitely consider doing a fluoroscopy. Okay. Because that's going to probably be the most useful if you are trying to find an IUD that's potentially, because you wouldn't do an X-ray necessarily during pregnancy. It's not an emergency,
Yeah.
But once the baby's out, you could do a fluoroscopy. The dimensions, I think this is a case where knowing the specifics of the IUD become more important. The Mirena is 32 millimeters by 32 millimeters.
Okay.
And so I think that's important. Why would you expect to see a Mirena on imaging? What makes it radiopaque?
I think it has some barium in it.
Correct. It has barium impregnated in the frame. So I think that's another important point to be aware. I think with all the pregnancy changes, term, it is completely feasible that you might miss it, although it's undesirable. It looks inadequate, but I think it's completely possible. So I'm not criticizing you, okay? Then I think the harder part though, and I want to make sure I understood this correctly, you did a laparoscopy and then a separate hysteroscopy?
No. So when I did her C-section, I just felt like I looked in her uterus and it wasn't in there. So I was like convinced that it was somehow outside the uterus. And so I ordered an X-ray on her and it showed up on X-ray. And it looked like it was in her abdomen, like kind of behind the uterus, but it was really like in the lower uterine segment. And so I did a diagnostic laparoscopy to look at her abdomen. I didn't see it. And so then I did fluoroscopy at the time of the diagnostic laparoscopy. And then it looked like it was in the uterus. And then I did a hysteroscopy and it was like in the, like kind of embedded in the lower uterine segment.
Okay, completely legitimate. I'm okay with this. I wasn't
Okay.
sure at first, but the reason I'm okay with it is because a two-dimensional X-ray certainly could lead to the conclusion you reached. You didn't find it in the C-section. It looks like it's behind the uterus. I totally get it. Then I give you credit though. I was worried that you took the patient out of the OR and then later brought them back for the hysteroscopy. And so I'm
No.
happy that was not the case. So I would say this is not the ideal scenario, but
Yeah.
I don't get the impression that it was for a lack of trying. Okay.
Okay.
So
And
yeah, go
do
ahead.
you think they're gonna get me on like just not ordering a regular ultrasound after the fact, like postpartum? Just, you know, we're starting from square one, you know, square one, missing IUD strings is order an ultrasound.
No, I would argue that given the scenario you described, I would probably do an X-ray because you were just
Okay.
uterus and did not see it anywhere.
Okay. Okay,
Okay.
good. Thank you.
So I think that the X-ray, and now we could argue hindsight's 2020. It could have been really great to do an ultrasound and an X-ray. That might have been the best approach.
Yeah,
But
definitely.
definitely, I think the X-ray is required. You were just in the uterus, and we would have anticipated that you would see it. So the fact it was very low down in the uterus and the changes in the endometrial cavity that occurred during pregnancy probably is what, and the bleeding that occurs during a C-section. You're
Mhm.
searching for a 3 centimeter by 3 centimeter device. It's plausible that you might miss it.
Mhm.
Okay.
Okay.
So yeah, no, I'm okay with this. This is an interesting case, and I agree with you. It's high yield.
Okay, thank you.
You're welcome. I'm going to move to our next person. Just one second. Dr. Joseph, can I come to you next?
Yes.
Okay, which list would you like me to look at?
We can do OB or office.
Okay. Okay, I swear I saw your name. Hold on, where is it? Sorry, for some reason,
I thought I saw it too.
yeah, I thought I did, and then I go back through and I'm missing it. Let's see here. Oh, there it
Here's
is.
one number. Yeah.
I'll tell you, let's do office. How about that?
Okay.
Okay, let's talk about case 21.
Okay.
So this patient, when she came in, what was she complaining of?
She was complaining of vaginal dryness and itching, and she had the diagnosis of lichen sclerosis that was diagnosed on biopsy by another provider.
Was she currently receiving treatment for lichen sclerosis?
She had tried treatment in the past, but at present, when I saw her, she was not.
Okay. Now, tell me, how would you counsel a patient if you did a biopsy and it came back lichen sclerosis about the management of that condition?
I would counsel the patient that it's possible that she would need, the treatment would be topical steroid medication, that it's possible that she would need this lifelong.
So how would you do the topical steroid? What steroid would you use and how would you dose it?
So I would use the clobetasol propionate cream, it's 0.05%. I'd have the patient use the cream every other day for a month, then once a week for another month, and then have her come to see me in the office and reassess her symptoms and see if there's any improvement, and tell the patient to use it possibly once a week for maintenance.
Okay. And how long would you recommend the maintenance therapy?
I'd recommend it for at least 3 months, and then we could reevaluate.
How would you decide whether to continue it or not?
I would decide based on if the patient has improvement, and then I would tell her she could discontinue the medication, and then if she starts having symptoms again, to restart it.
Are patients with lichen sclerosis at increased risk for cancer?
They are. They have an increased risk for squamous cell carcinoma.
Does medical treatment of lichen sclerosis reduce the risk?
I believe that it does, yes.
But you would not recommend long-term maintenance therapy if their symptoms improved?
I would not recommend it, but I would see these patients. I would recommend like an annual exam, and so I would evaluate these patients and see if they would need to continue the medication.
So if it might decrease their risk of cancer, why wouldn't you recommend long-term maintenance therapy?
Um, like I said, I think that they could use it lifelong. I just wouldn't, since it's a steroid cream, it's just something I wouldn't have them continue if their symptoms have improved and they're not. If their symptoms have improved, I wouldn't have them continue it.
Okay. You also started this patient on vaginal estrogen therapy. Did you put her on progesterone?
I did not. She is using the vaginal estrogen cream twice a week, and I did not put on progesterone.
Will you discontinue the estrogen if the patient's symptoms improve?
I usually have them continue with the vaginal estrogen for lifelong, but I do have some patients that will discontinue it if they feel like their symptoms have improved, and then they'll restart it back up. But for the most part, I tell my patients for the vaginal estrogen that they would continue it.
Can you give a patient with a history of breast cancer vaginal estrogen?
You can, because it's not, there's a low systemic absorption with vaginal estrogen with the history of breast cancer. It's not something that I like to do. I counsel the patient about the risk of small absorption, systemic absorption, and I would have them discuss, and I would discuss it with their oncologist prior to starting them on vaginal estrogen. If the patient has a history of breast cancer, I really try to avoid vaginal estrogen therapy.
Okay, so a couple of very high yield topics in a relatively simple case. And
Yeah.
I'm just going to go back through first talking about the thing we just talked about, the vaginal estrogen. In the patient with a history of breast cancer, the key thing that you mentioned was coordinating with the oncologist. Completely agree with that. And so that I would answer it exactly the way you did. There are some other options that could potentially be used. There, I think, is a recent ACOG in the last year publication on this topic, talking about other things like vaginal prasterone, I think, is another option that could be used. Yep. So again, I like the way you answered that question. I agree that often we do use vaginal estrogen long term, and we don't recommend progesterone in the typical dosing, which would usually be less than 3 times a week or less, because there's not an evidence that you need to protect the uterus because of the low level of hormone that's being administered and the lack of significant systemic absorption. Regarding the lichen sclerosis, I agree with everything you said, except the one problematic issue here is that it does appear, although the risk of cancer is low, it is an increased risk with lichen sclerosis, and it does appear that there's probably some reduction in cancer risk with long-term maintenance therapy. So I think at a minimum, it's kind of a shared decision making with the patient on that issue, okay? Because long-term maintenance therapy once or twice a week would generally be low risk and would potentially have some benefit both for preventing recurrence of symptoms and also possibly lowering the risk of squamous cell carcinoma. Okay.
And do you have any recommendations in terms of the regimen? Because that's the one that I use in terms of how I tell the patients to use it. I can't find a consensus, so I don't know if my regimen is sufficient.
The usual regimen is clobetasol, which is what you told me, I believe, right?
Yeah, that's
and
what I use.
How you dose it. So a lot of people will do daily for a period of 2 or 3 weeks. You said you do every other day for a month, and then decrease it down to either once or twice a week for maintenance therapy. I don't know that there is a single regimen in those different options that has been proven to be better than another. I think the key thing is that maintenance therapy is twice a week or less. And that would be what I would consider there. The period of time that you do the initial therapy, again, there's multiple different ways people do it. I think the key here is a little bit higher dosing for the initial treatment, and then with improvement, then reduction of dose for maintenance. And I think there's multiple options that would be acceptable. Okay.
And then continue it because of the risk of cancer prevention.
Yeah, I mean, I think it's a twofold reason. One is it can lower the risk of cancer, and two is it can reduce the risk of recurrent symptoms because it is a chronic condition. So most patients who discontinue therapy will get recurrent symptoms at some point in time. And this can be problematic because the symptoms can often be significant. So those two things, I think the cancer risk reduction, although it is a very slight increased risk, I think it's still a relevant part of the shared decision-making with the patient for long-term maintenance therapy. Okay?
Thank you.
Yeah, you're welcome. All right, let me go to the next person. Dr. Snook, I'm going to come to you next. And let me just get your case list. Which list would you like me to look at?
Can we do OB?
Sure. Okay, let me ask you about case number 23 for a second.
Okay.
So this patient was in a substance use program because of her heroin use?
Yes. Well, so she had a history of heroin use. She was no longer using, and she was already on Subutex when she entered care with us.
Okay, tell me about the optimal management of opioid or heroin use during pregnancy?
Well,
So let me
so
ask you some specific questions. Do you favor keeping a patient on an opioid agonist, or would you prefer to do medically supervised withdrawal?
so I would prefer to keep the patient on her opioid agonist due to the risks that can come with supervised withdrawal to her and the fetus, and risks of going back to using the heroin.
Okay. In using an opioid agonist, would you prefer methadone or would you prefer Subutex?
Well, so oftentimes I'll keep the patient on what they are on, but if they're not on something already, and if I had to choose one, I feel like Subutex or buprenorphine tends to be a better option for our patients. It's a partial agonist, so there's a little bit, and so because of that, it doesn't have to be quite as closely monitored. The patient doesn't have to go somewhere daily to get the medication, and therefore there's less, and that's because there's less risk of like overdosing or using it incorrectly, since it is a partial agonist. And like I said, the other benefits is that they don't have to go somewhere daily, which I feel like that's a very challenging limitation for our patients in our population.
Is there any difference in neonatal abstinence between the two medications?
I believe that I think overall, no. I think buprenorphine may have a little bit lower risk, again, with it being a partial agonist versus a full agonist of the opioid receptor.
Regarding the dose, is there a benefit to, when a patient is on opioid agonist therapy, to trying to titrate to the lowest effective dose during the pregnancy? Does that reduce the risk of or reduce the significance of neonatal abstinence syndrome?
So you mean like trying to titrate down during pregnancy, or?
Right. So trying to have the patient on the lowest dose that is effective for them, with the goal of reducing the risk of neonatal abstinence syndrome?
I mean, I think that makes sense. But again, I tend to keep patients on the dose that they're on, just again due to the risks. I feel like there's a higher risk for the patient of with the risks of withdrawal and the risks of potentially reverting back to using opioids or illegal substances. So I feel like the benefits of keeping them on their normal dose and preventing that from occurring outweigh those potential risks with the neonatal abstinence syndrome.
Okay, I'm going to stop here and I'll give you some feedback. I agree with pretty much everything you said. My assessment of what you would what the key concept is that you were kind of focusing on, and I think this is correct, is that we would like to effectively manage the patient so that they are off of substances of abuse and on treatment. And we're just that's the goal, not to get the lowest dose or not to get them off of agonist therapy during pregnancy because of the risk for relapse, or even using on top of treatment, which would be undesirable. So that's really the bottom line, is that in this situation, we want to maintain the patient so that they're not using drugs of abuse, that they're using the treatment therapy only, and we want them to be stable. And there is not a dose-dependent relationship to neonatal abstinence syndrome so far as we know. So even if you had them on a lower dose, it doesn't necessarily impact the risk for neonatal abstinence syndrome. The other thing, there is a slight lower risk with Subutex for neonatal abstinence syndrome. I don't think it's overwhelming, but I know ACOG mentions it in their committee opinion on this topic. But otherwise, everything you said, it is a partial agonist. If patients on methadone, they're doing well on methadone, we're not going to mess with that, because
Right.
again, we want to keep them stable. So I like that as well. So yeah, I think the other thing I want to mention about this, not everybody has a patient with opioid use disorder on their case list. I think if you don't, you need to look at this ACOG committee opinion to know the basics, just because I think it's a common enough problem nowadays that it could easily be a structured case as well. I'm going to stop there. Do you have any questions for me before I let you out of the hot seat?
No, I don't think I have any questions. Thank you.
Okay, yeah, good job. Thank you very much. Let me just mute you and I will go to the next person. I'm going to come back to Dr. Equinande really quick and see if we have solved that. Just a second. Dr. Equinande, are you there? So I am trying to unmute you. Now I think it worked. Are you there?
Hey, yes, I'm here.
Oh, awesome. All right. So I am going to go to you next, if that's okay.
Okay.
Which case list would you like me to look at?
Your choice.
Okay, let me just get to it here. Let me find it. Did I skip by it? Let's see here.
You should be.
Did you see it when I was down the list?
No, well, I actually just sent in my list this morning, so I don't know.
Okay. So we did not have it before today.
No.
Okay, then it probably has not been added. It'll probably be added tomorrow, would be my guess.
Oh, okay.
Okay, so that's fine. Let me ask you this. I'll just ask you a sort of a structured case, if that's all right.
Okay.
Okay, so let's see here.
Oh, snap.
What's that? You all right?
Sorry, I'm on call. Hold on.
No problem. Feel free.
Hey, Dr. Equinande. Yes. Excellent. All right. Thank you so much. All right. Bye-bye. Sorry about that.
Oh, no problem at all. Okay, if you are ready, I have a question for you.
Yes, I'm ready.
If you had a patient you see for a new OB visit and you do your new OB labs and it comes back HIV positive confirmed from the lab, what would you do?
Okay. So first thing I would do is, confirm again with the lab that this did indeed test positive, and also review the patient's prior lab history. Like if I've seen her before, like preconception, if she'd had a prior positive a prior HIV test, and if it was negative before. Then I would, if the lab comes back and says this is indeed positive, then I would bring in the patient and talk with her to try to get a history of you know, like any recent exposure that may have occurred, and of course disclose to her what the lab findings are.
Okay, if the lab findings are confirmed and the patient has no relevant history of past, all her past tests were negative and she has no concern or idea about how she might have contracted HIV, but she is in the first trimester of pregnancy, which is why she came to see you in the first place, what would you recommend next?
I would order like a viral load to see. I'll order a viral load, and if again we're confirming this is still HIV, I would treat.
What would you treat her with?
I would treat. I don't know HIV drugs. All I remember is like tenofovir.
Now, I want to ask you, in real life, would you treat her?
Oh, sorry. Yeah. So no, I would not treat her in real life. I would actually place a consult to ID.
Okay. Now, I'm going to give you feedback for 1 second, and then we're going to get back into the discussion here. Okay. But there's no doubt in your mind that she needs to be treated, correct?
Correct.
And there's also no doubt in your mind that this is an area that you don't routinely handle, correct?
Correct.
So I want you to convey that to the examiner. I know that she needs treatment. This is not a treatment that I usually prescribe. I would consult ID. I would refer her to ID or to MFM or whoever manages this. Usually it's going to be infectious disease, but I would refer her there to begin. And then here's the question. Are you expecting them to start single agent therapy or multiple agent antiviral treatment?
I am expecting multiple agent.
Perfect. So I would refer her to infectious disease for initiation of combination antiretroviral therapy, or if you want to say HAART therapy, highly active antiretroviral therapy. Okay.
Okay.
And they're not going to say, "Oh, good job," make you feel all warm and fuzzy. But if you tell them that, you have accomplished what needs to be accomplished in an appropriate way. Okay.
Okay.
So let's get back into the discussion. No more feedback for a moment. Let's assume that she goes to infectious disease and they prescribe her combination antiretroviral therapy. What will you do during her prenatal care and delivery to try to reduce the risk of vertical transmission?
Okay. So of course, during her routine prenatal care, we would continue encouraging her to take her medication. I would, working with infectious disease, monitor her viral load to check like response of treatment and reduce vertical transmission. And at time of delivery, if her viral load, can't remember the cutoff, she has a low viral load, I would counsel her that she could have a vaginal delivery bearing any other obstetrical indications. However, if she has a viral load, I believe it's greater than 1,000, I can't remember, then she would need to deliver via cesarean section.
Okay. If her viral load is greater than 1,000, what gestational age would you schedule her C-section?
I would schedule her C-section at 37 weeks.
And is there anything else that you would do around the time of delivery for a patient to reduce the risk of vertical transmission?
Yes, I know that we do give them treatment. I can't think of what the treatment is right now, but we do give them treatment prior to this cesarean delivery.
Okay, what about the patient who is going to have a vaginal delivery? Would they get treatment?
If her viral load is low and she's been compliant, actually, no, I don't believe so, if her viral load is low.
Okay. Let me ask, I'm going to stop here. Let me ask you, do you have any HIV positive patients in your OB list?
No.
Okay, and that's not uncommon. A lot of us don't have this on our OB list, and there will be some people that have multiple cases on their list, smaller group of people. This topic, and I bring it up relatively frequently with exam pro sessions because it is one of these topics that is really fundamentally important. There are some OB things that we have to know because we would be the person who might be making those interventions. So I appreciate you working through it with me. And let me just give you some feedback here. First of all patients with HIV are going to be treated. So when we make the initial diagnosis, we're going to recommend treatment for sure with combination antiretroviral therapy, as we talked about. I love the fact that then you talked about at each prenatal visit, you would confirm and encourage compliance with the treatment regimen. That is a really important point because vertical transmission risk, worst case, is about 25%. And if we do everything right, we can get it down to below 1%. But one of the prerequisites is the patient has to be compliant with therapy for that to happen. So I was really happy to hear you mention that. And then there are a number of things you could talk about, but the key thing that I want to focus on is the delivery planning. Around 35 to 36 weeks, you're going to check a viral load. If the viral load is greater than 1,000, that is the correct number, greater than 1,000, then you're going to schedule a cesarean delivery, and you're going to schedule it at 38 weeks. That's the recommendation, okay? We're doing it a little bit earlier than 39 because we're trying to avoid labor or rupture of membranes. We will give the patient AZT starting 3 hours before the cesarean delivery. For patients with AZT, yeah, starting 3 hours before. For patients with a viral load less than 1,000, they can have a vaginal delivery. There's no benefit to a cesarean delivery in that case. If they have a very low viral load, less than 50 or undetectable, then they don't even benefit from AZT. If it's between, say, 50 and 1,000, then it's a shared decision-making process, but most people will give the AZT because of potential benefit. And it would be started when they come in labor and continued until delivery. And there is no recommended induction. It's like you said, the vaginal delivery would be for standard obstetric indications. And then the other thing that we want to do to try to prevent vertical transmission, we want to avoid anything that's going to potentially disrupt the fetal skin barrier to infection. So, fetal scalp electrode, anything that's going to traumatize the fetal skin, we would like to avoid. I think those are the key points. So any questions for me before I let you out of the hot seat?
No, I think that's it. Thank you
Okay,
very
good.
much.
Yeah, no, I appreciate you being patient and going through this scenario because it is really important. We all have to look at this. If we don't have it on our list in particular, we may not be as familiar, comfortable with it. And there are some key points that just need to be addressed if they ask you a structured case on this, or if they bring it up in the case list. So good job. I'm going to let you out of the hot seat and we'll keep. Dr. Murray, can I come to you next?
Yes.
Okay, just give me 1 second and I will get your list. And I think I must have skipped by it. Hold on one second. Did you see it when I was going down the list? Did I?
I don't see it on there.
But you did submit it.
Yeah.
Okay, hold on one second. Let me try one other thing. I'm gonna just go back, see if it's in a different folder. Just one second. Okay, I don't see it there. Hold on one more second. Okay. Sometimes if I refresh, it will show up, which is really strange. I don't know why that works. Let me see here. All right, I'm going to reach out to ExamPro and I'm going to ask them to investigate this, okay?
Okay.
Because I don't see the case list. Just one second. Do you have any idea how long ago you submitted it to them?
In August.
Oh, okay, yeah, that's ridiculous. Okay, I'll reach out to them as soon as we finish and I will find out.
Okay.
If you don't mind, I'll just ask you about a structured case sort of deal, if that's all right with you. Okay.
That works.
So let me just think here for a second. All right, let me ask you this. On your case list, do you have any vaginal hysterectomies?
I do not.
Okay. But you do have hysterectomies, right?
Yes, I do.
When you list a hysterectomy on the case list, does every single one of your hysterectomies say cystoscopy with it?
It does not. It's probably about half and half for me.
How do you decide when to do a cystoscopy at the time of hysterectomy?
So when I initially started doing hysterectomies, I was not doing cystoscopies, and as I got further in my first year, I started adding it routinely, just for reassurance. However, with cases that I am more highly suspicious of having a ureteral injury, if the case is particularly complicated, if I have concern that I was close to the ureter, or if there's significant adhesions or something along those lines, and then my threshold to do a cystoscopy is higher.
Okay. So if you did a cystoscopy following a hysterectomy and you don't see efflux from one of the ureters, what would you do?
If I don't see efflux from the ureters, I would initially start with having anesthesia administer indigo carmine, because sometimes it's just hard to see ureteral effluxes without having some sort of dye or other solution. If despite that I didn't see reflux, I would consult a urologist to come help me with that case. Potentially, this is not something that I would feel comfortable doing, but potentially doing ureteral stenting to see if there's any obstruction.
What would you do if urology wasn't available to come to the OR at that point in time?
I would at least, when I do cystoscopies, the abdomen isn't closed yet during whichever form of hysterectomy I choose. And so I can assess the ureter intra-abdominally and see if I'm seeing peristalsing, any areas where I think the ureter might be kinked, or any thermal injury or any other obstruction that could be causing it for me to any injury that may be causing me to not see the ureteral efflux.
Describe for me the course of the ureter, which is where I assume you would be looking to identify any possible problem.
So the ureter starts from the renal pelvis and descends laterally along the psoas muscle and then crosses over the pelvic brim, and then it descends just inferior to the ovarian fossa. It crosses under the cardinal ligament, and then inserts into the bladder, which travels a couple centimeters before inserting into the trigone and effluxing. I would primarily look in just over the pelvic brim along the area just inferior to the ovarian fossa, and particularly near my vaginal cuff. And I do incorporate uterosacral ligaments in my cuff closure, so looking to see if there's any issue where that would be an area that the ureter could be kinked.
Okay. Assuming that you don't find anything obvious looking above and urology is still not available, what would you do?
I would finish the case and monitor the patient's urine output post-operatively, specifically in the PACU. I could try avoiding trial or potentially just keeping the Foley in until she's able to get to a urologist outpatient.
If you have a complete ureteral transection, is a Foley catheter or avoiding trial going to offer any benefit?
No, it won't. If there's a complete ureteral transection, she would need likely operative intervention.
And okay, I'm going to stop there. So the bottom line, the end of the case is that until the urologist actually sees and evaluates her, it's not settled, which I think you made clear that even if you take her out of the OR, which you might have to do, you would then consult urology urgently as soon as they're available to come evaluate the patient. And if there is an injury that's identified, then to fix the injury. So that's the key. But I think everything that you said going backwards from that point was very reasonable. In the initial cystoscopy, some people will talk about giving IV fluids or giving Lasix to try to promote increased flow through the ureters. I think that's reasonable. If you happen to do that, you could mention that. I think mentioning some type of dye, you mentioned indigo carmine, I think is completely appropriate because it may make it easier to visualize efflux from the ureter. I definitely favor consulting urology or urogynecology, whoever your usual consultant would be in the exam. They expect you to consult when you would normally consult. They just are not going to accept that as the final answer, okay?
Right.
So they'll tell you they're not available, okay? And then the discussion regarding changes in your practice as you gain more experience, I think is completely reasonable. It's somewhat of a judgment call whether to do cystoscopy with all hysterectomies. It's not, it is required if you do any urogynecology type of procedure, but not necessarily for just a routine hysterectomy. And I think the advantage of doing it is that if there is an unrecognized injury, you'll be more likely to diagnose it if you are routinely doing cystoscopy. So I think that is, you can go either way with that. I don't think there's a right or wrong. I will, like I said, reach out to ExamPro about your list.
Okay.
Do you have any questions for me before I let you out of the hot seat?
I guess my only other question would be, so let's say if the case had continued and there was a transection and urology still not available, would the answer then have just been to decompress with a Foley and, like, I guess,
So
you know, because obviously I'm not going to fix it myself.
Yeah, I would think about if there's going to be a delayed consultation by urology and you really had no efflux from the ureter, I would do the imaging, an IVP or a CT urogram. I think IVP is actually going to be the preferred one to find if there is evidence of an injury. If there is evidence of an injury, then you might need to do drainage of the kidney with a percutaneous nephrostomy tube, which would be done by radiology.
Until urology could.
Yes, and if I'm thinking if urology can't see a patient within 24 hours, you may have to transfer that patient to a higher level of care where they're available. And if you're gonna have that delay, you better to decompress the kidney. Although my recollection on this is you have 48 to 72 hours before you would anticipate any, serious permanent kidney injury. But still,
Okay.
you really don't want to delay if at all possible. And so the percutaneous nephrostomy tube has very little downside if there is a delay. Okay.
Okay.
Yeah.
Sounds good.
All right.
Thank you.
Yeah, you're welcome. All right, I'm gonna go ahead and at this point, I am looking if there are any questions because we are reaching the end of this session. And I do want to point out there is a regularly routinely scheduled Sunday night webinar tonight. I just wanted to make sure everybody knows that at the usual 8:30 time. This is actually a makeup webinar. If there are any questions, what I'm going to do is I'm going to take down the raise a hand on everybody. If there are any questions, if you want to click the raise a hand, I'll try to answer any questions. Okay, hold on 1 second. Dr. Joseph, did you have a question?
I did. For the patient, the HIV patient scenario, would you not use a vacuum if you was going to deliver vaginally?
Yeah,
I just wanted to.
I'll tell you, vacuum and forceps do run the risk of breaking the skin barrier, so my preference would be not to. I think with a patient, you could get into a shared decision-making process with a patient with an undetectable viral load who has what would be thought to be an easy vaginal delivery versus doing a C-section, meaning you felt like you could easily put vacuum or forceps on. My mindset on this is that forceps might be a little bit less likely to traumatize the fetal skin, but I think the general approach is try to avoid operative delivery because of the risk of breaking the fetal skin and because HIV is a life-threatening condition. Okay. I can't remember how ACOG words it in their publication. I should really take a look at that, but my preference is I would favor not using a vacuum or forceps in an HIV positive patient. Okay?
Okay. Thank you.
You're welcome. All right, I'm going to go ahead and wrap it up here. I want to thank everybody for joining us. Again, there will be a regularly scheduled webinar tonight at 8:30 p.m. Eastern, 5:30 p.m. Pacific. Have a great night.